Cool. Good evening, everyone. Thank you for giving me the honor of sharing some of my thoughts on trauma and pregnancy, which is essentially a situation of double jeopardy. It's the management of the pregnant trauma patient is often considered difficult for various reasons, and some of them being the anatomical and physiological changes that we expect. There's difficult identification of pregnancy-specific complications. It's the rarity of presentation, very difficult patient group to risk stratify. We also have a difficult prediction of outcomes for mom and baby, and we have patient and practitioner fear of radiation exposure. And because it concerns two patients, it results in a greater cognitive burden on us as healthcare practitioners. And there can often be an incorrect diversion of attention towards the fetus. And the need for a multidisciplinary approach also further jeopardizes uncomplicated management in these patients. We'd start with a little evidence-based preamble. What does the literature say? So I looked at a systematic review that was done quite recently. And what this review found was that it actually is a pathology that affects 7% of all pregnancies. The commonest causes of trauma being, number one, MVAs, and number two, this was very sad, intimate partner violence. And this just also emphasizes that in the ED, it's the ideal doorway to screening for IPV, especially in patients with minor injuries that are pregnant. And the commonest complications that this review found post-trauma in pregnancy was maternal death was the number one complication, minor maternal injuries, preterm labor, abruptures, and intrauterine fetal deaths. What they did find across the studies that they looked at was that maternal stabilization is paramount. And often simple diagnostic modalities are all that you need. But because it's very difficult to do an RCT on trauma and pregnancy, they concluded that more studies are needed. So there wasn't a lot on that topic. So in order for us to sort of go through an approach to trauma and pregnancy, I thought we'd discuss two cases and just looking at the basic management approach to both cases. So case one, we have a 19-year-old female. She is 28 weeks by unsure dates, unbooked, and allegedly fell and was complaining of a painful face, chest, and left wrist. So a little bit of a dodgy history there. We do a quick primary survey, which is unremarkable. She's hemodynamically stable with normal vitals. And a secondary survey revealed a swollen left wrist with decreased range of movement. She had a tented left clavicle with very superficial facial bruises. So in our actual presentation, we did ask people if they would have an approach or they'd like to give us a quick answer of how they would approach this patient. I don't know if we have enough people.
Yes, we do. Yeah. We've got a good number of people on the call. I'm going to suggest that we ask Francois to tackle this one first.
Hi, is my audio coming through?
Yes.
Okay. So yeah, I think first things first is we've already got our primary survey, so we know the patient's stable. Like I mentioned already, we have this history of this alleged fall, but the injuries already are starting to raise some red flags in terms of the presentation according to the mechanism of injury. I think it would be important to try and make this patient feel safe as much as possible already if we are potentially considering some degree of interpersonal violence as well. So if it is a female patient in this regard, it might be important to just have an approach initially when talking to her to ask if she feels comfortable with any male examiner, which you prefer to have a female doctor, and then also maybe put in the place of privacy where she can feel safe to maybe open up to us. In terms of the secondary survey as well, it's obviously important that we just check that there aren't any life-threatening injuries associated with anything that could put mom or baby at risk. So we'd have to examine that wrist itself, and for the tented left clavicle, I think it's important also just to examine the chest and make sure there's nothing associated with that. and then do a full examination of any the facial bones and the orbits, eyes, look for any signs of any dangerous fractures related to that base of skull or anything like that as well. Manage her pain appropriately as well. Obviously, it's going to be difficult because she's 28 weeks as well, so it does make it difficult. And I think it is important to verbalize to the patient as well that you are aware of the pregnancy and that you will be treating her with that in mind. But obviously, we need to treat her to first and make sure that she's safe. Otherwise, if she isn't safe, the pregnancy itself is also at risk. I think in terms of the left wrist and the tented left clavicle, it's going to be important to get some degree of imaging for her. And I think it's as long as we're open with the patient and counsel her and talk to her about the risk of radiation in pregnancy at 28 weeks about this, I think x-rays would be quite beneficial. In this case, and we can offer shielding for her as well. I guess the nice thing is that the fractures themselves are not necessarily associated with the abdomen, so we can ask them also to try and do targeted x-rays in the areas themselves while she does shielding as much as we can of the abdomen at the same time. And then ultrasound as well is going to be vital here, just to make sure that there isn't anything underlying as well, our basic EFASTs, and also as well to just do a sonar of the pregnancy and make sure that there's still a fetal heart and fetal movements process, and just to communicate with the patient throughout what's going on. I think we'd start with simple analgesia in her case, just in that regard, some Panado, and see how we go with that. And then obviously speak about upscaling for that, just explain the risks that come with other potential modalities of pain management as well.
Thanks so much, Francois. That was actually a very comprehensive, beautiful trauma approach answer. And I think you covered most of the goodies that we wanted you to pick on, which included your quick management, including analgesia, imaging options we're going to talk about now as well. And you talked about her making her feel safe and the hospital being a place of safety. And the only thing I would add to your answer would be, given that she's unbooked, this would be a window to initiate antenatal care or get her into the booking blood route. So based on your answer, we're going to go through a few of the questions that you clearly thought about in your mind, which included imaging and analgesia, which is some of the things we come across in our stable pregnant patients. Imaging in pregnancy. So as Francois already mentioned, shielding is super important, especially when it comes to pregnancy. And we should be maintaining the basic ALARA principle, so time, distance, and shielding as low as reasonably achievable. So when it comes to imaging in actual pregnancy, it's often an ethical and medico-legal dilemma for many clinicians. And from our side, it's always important to explain the risk-benefit to the patient, and obtained a signed consent form prior to any imaging. So in order to better explain the risks to your patient, I thought we'd go back to a little physics. So there's different types of radiation. When we do an ultrasound, you are exposing baby to non-ionizing radiation, or if you remember the actual principles of ultrasound, it's just sound waves or Doppler effect. Actual radiation that we expose patient to, there's two types. You get an absorbed dose, which is measured in units of Gray or rads, and you can get an effective dose, which is sieverts or rems. And the actual highest risk of fetal anomalies to the fetus is in week 2 to 8 of life, obviously when all your vital organs are developing, especially cardiovascular structures. And it actually takes more than 50 milligrays to cause any fetal developmental impairment. So bearing in mind that 50 is our golden number, you'll have a look at this graph, and it was actually very interesting, and I learned a lot from doing this research. But a lower extremity or any peripheral x-ray like a wrist or an ankle exposes mom and fetus to 0.001 milligrays. A C-spine x-ray is also 0.001. A standard chest x-ray is 0.01 milligrays. Pelvic, CT head and neck, and a CT abdomen is all around the 1 to 1.4 milligrays. And it's only a CT pelvis that exposes the fetus to the highest dose of milligrays that we can offer, which is 25. And it's not even close to the dose of 50, which can cause fetal developmental issues. And according to the ACOR guidelines or the American College of Radiology guidelines, other modalities of imaging that you can offer your patients are MRI and ultrasound, and they've dictated that it's not associated with any fetal risk, and it is the gold standard of choice. If you are offering your patient an MRI for whatever reason, not maybe in our setting because it's not always available, in private one day, bear in mind that the use of gadolinium contrast with MRI should be limited, so you can use a half dose. And the bottom line is, don't withhold any imaging from mom if it's in her best interests. And although this seems like a graph and it's not something we really remember, it's good to have this information, especially if you're discussing your imaging with your friendly radiologist and you need to know to say, hey, I've got the evidence here as per your American College of Radiology guidelines. This is why I think mom should get this imaging, so there shouldn't be any major risks. And in fact, ACOR also recommends that you only need to shield the abdomen when the imaging is in close proximity to the fetus. So if you're doing a pelvic, not doing a pelvic x-ray or something in close proximity to the uterus, like C-spine, according to ACOR, you don't actually have to shield the abdomen, but sometimes it makes us feel a bit better. Bottom line, don't be afraid to order the necessary investigations, and maternal health is always equivalent to fetal health. And the next slide is just a little perspective that besides us helping to the numbers, we are actually exposed to similar amounts of radiation over crazy extended amounts of time that we'd be exposed. Okay, so going into the next slide, Francois mentioned analgesia, and he which was great because if I have a fractured disc, I definitely want some analgesia. And he did mention Panado as a starting choice, which is great because we always start with the analgesic ladder. However, if you do have a fractured disc, maybe you might want something a little stronger. And first line is, yes, paracetamol. And second line is actually opiates. You can go for something a little more cardiovascular friendly like fentanyl. But importantly is, don't withhold analgesia from your pregnant patients. It's really important that we consider it and we offer it to them. But the main thing that you would want to avoid is NSAIDs, because once mom hits 24 weeks, there is a risk of spontaneous ductus arteriosus closure. So that would be the one analgesic that you would definitely want to avoid. Going into the next slide. So we mentioned that this mom in the scenario was 28 weeks by unsure dates. So now that she's had a possible intimate partner violence episode, and if she fell on her abdomen or whatever it is, whatever the scenario was, do you admit her for monitoring, and for how long? So who do we monitor? So there's two types of monitoring. You can get subjective monitoring, which is your maternal fetal kick charts, and objective monitoring, which is obviously a little more gold standard. And this includes a CTG for 4 hours, which you can extend to more than 24 hours if mom is actively contracting, or she's got significant uterine tenderness or irritability, or an abnormal CTG, or active PV bleeding, or she's ruptured membranes, or she's also just a polytrauma and she's got major maternal injuries and there's still a fetal heart. So if mom is over 24 weeks, which she was in this case, she would need continuous fetal monitoring for at least 4 to 6 hours, unless she meets any of those red flag indications for 24 hours. Obviously, maybe I'm not sure about Rahima ED, but in most EDs, we don't have a CTG monitor. So here you'll have to coordinate with your friendly gynecologist to try and admit mom for CTG monitoring if indicated.
So just to answer your question, Rahima, we don't have a CTG machine, NST machine down in the ED. And one of the main reasons being is we still want to refer these patients for an obstetric opinion. We don't want to be the ones only seeing the patient, looking at a CTG and sending a patient home. Also, one other point, remember it's called an NST, non-stress test, if the patient is not in labor. Cardiotocograph is if she's in labor, yeah.
Okay, so we'll move on to our second case, which is the polytrauma pregnant patient, which obviously, for obvious reasons, often gives me palpitations when I've come across them, and very rarely. But let's just go through a quick approach to the polytrauma patient that is pregnant. So case 2 is set up with 32-year-old female. She was involved in a high-velocity MVA. It was a T-bone impact, and she was a restrained driver. She is 30 weeks by shore dates, had normal booking bloods, and a good antenatal history. You do a quick primary survey, and you find that her airway is maintained but threatened currently due to her low GCS. Her C-spine was immobilized at scene by EMS. You move on to breathing. She's got decreased breath sounds over her left lung zones. Her SATs are 90% on a poly. When you move on to circulation, she's got a blood pressure of 101/85. She's tachycardic with a pulse of 120, a cap refill of 2 seconds. Pelvis is stable for now, and she's got an open left tib fib fracture. Her GCS score is a 12/15. Her pupils are pinprick bilaterally. She is moving all limbs except the fractured limb, and she's got a glucose of 5. So once you're prepping lines and you're pulling your gas, her GCS drops to a 6, and your intern is still looking around for the ultrasound machine. Does anyone want to take a quick gamble as to how they would just very briefly manage and stabilize this patient, and anything you would change given that she's 30 weeks pregnant?
So I'm going to ask Fatuma to tackle this one because this is a nice dip-egg question.
Connect her to the monitors in our ED, continue that C-spine immobilization. So at that point, then we are going to have to prepare to protect the patient's airway. So while we are prepping for everything, we can start bagging the patient, get our SATs monitoring. I know with pregnant patients, there is concern because of the gravid abdomen. So that increases the risk of aspiration. So it is a full stomach. So with them, you are going to have to do a rapid sequence intubation. It has to be done quite fast. Decreased breath sounds over the left side of the chest. I'm assuming heart sounds are fine. So I am concerned about a possible tension pneumothorax on the left side, in which case you would have to do some needle decompression. So for a hemothorax, you can insert an ICD.
Cool. And how would you tell the difference?
So with your hemothorax, you do have your decreased breath sounds. There's often the dullness to percussion, as opposed to hyperresonance with a pneumothorax or a tension pneumothorax.
And in a very noisy ED where everybody's shouting and there's lots of alarms, what's easier than percussion?
Doing your point of care ultrasound, so you can do a fast that will detect.
Cool. Okay, I'm going to let Ashmika continue.
Thank you so much. That was actually a very good answer. Thank you for attempting. So what I'm going to do is we're going to go on to the next slide, and we're just going to go through a few of the nuances to management or a few pregnant polytrauma pulls. The principles of stabilization remain essentially the same. And the main things to remember is that maternal resus is equal to fetal resus. So like you've already said, Doc, we expect this to be a full stomach. It's a difficult airway and it's a full stomach. She's technically a high BMI. So some of the things that you'd want to look out for when you are going down there is to be prepared for a full difficult airway. And that includes having rescue airways, having a different view, so a direct and gyroscope, be expectant of airway edema, and this is because of it's associated with progesterone-mediated increase in total body water. There's a lot of mucosal friability in your pregnant patients, so there's a lot of increased likelihood of bleeding during airway manipulation, so expect that. Make sure you've got your suction ready. Like you mentioned, they have obviously at an increased aspiration risk because they're a full stomach. Plus, they have a decrease in their lower esophageal sphincter tone and increased intra-abdominal pressure from the gravid uterus. So you should try to avoid PPV to pre-oxygenate these patients, and obviously as minimal bagging as possible. Then something else that would be nice to pick on is the drugs that you're going to use to intubate your patient. So obviously we're assuming that she's a head injury, and we're intubating of a low GCS. And most of our TBI drug studies do not involve pregnant patients, and they do recommend ketamine. And in this case, I wouldn't tailor that to her pregnancy at all. Not thinking about the fetus, the ultrasound is not available. It's purely maternal resuscitation that is the gold standard here and the most important thing. So as it says there, tailor your RSI meds as per maternal need, not for fetal risk. Then once you've hopefully successfully got your airway in, remember that there may be slight ventilatory differences that you need to consider when you're setting your vent. And that in pregnancy, they have increased oxygen consumption. They have a decrease in their total lung volume because of the upward displacement of the diaphragm. Your FRC is much smaller because of the gravid uterus, and they have a decreased apneic supply. So if you're pre-oxygenating a standard non-pregnant person, they might maintain their pre-oxygenation apnea for a longer time, but pregnancy, they desaturate much quicker. They also have a physiological respiratory alkalosis, and the fetus may not be very tolerable or permissive of permissive hypercapnia because of the increasing acidosis that results. So these are just a few things to remember when you're setting your vent. Going into the next slide, this particular patient had decreased air entry over her left zones. So we've already thrown around a few differentials. Is it a pneumo? Is it a hemo? Is it a flail chest? Whatever. But basically she needs a drain. So just some special considerations with your ICD. As mom progresses in a pregnancy, there was a few studies that show that there may be cephalad displacement of the diaphragm up to 4 centimeters. So some authors suggest insertion of a chest tube in the 3rd or 4th intercostal space because you don't want to push your tube into a spleen or a liver or a diaphragm. So obviously this is given taking into consideration how far mom is in a pregnancy. Important pulse for circulation in pregnancy in the polytrauma patient. Left lateral position is always mandatory, and or manually displacing the uterus to the left. And thinking about things like aortic valve syndrome, and as considering the physiological changes that happen during pregnancy, moms will obviously have, excuse me, if they're presenting with features of shock, so they're hypotensive with increased cap refill and a tachycardia, in pregnancy that will suggest end-stage shock. And if mom has a normal blood pressure, don't let it fool you. She's not in shock. And this is because of the increased physiological flow during pregnancy. Moms take a little longer to actually go into end-stage shock. If you're going to give mom blood products, always remember that it needs to be rhesus negative. And if this particular mom had a stable pelvis, but say she had an unstable pelvis, would you apply a pelvic binder? Always yes. Obviously, you're not going to apply it over a gravid abdomen, but remembering that your pelvic binder should be placed over the SAIS and your greater trochanter's. And you should not prevent pelvic stabilization because you're worried about a fetus. Then if this mom had to arrest for whatever reason, she went into spinal shock or severe hypovolemic shock, or because she's a polytrauma patient, the principles of cardiac arrest essentially remain the same. The main things would be to displace the uterus to the left, consider a resuscitative hysterotomy at 4 minutes into your trauma algorithm, which we'll go over quickly now. And then to just remember that normally we go through our H's and T's in trying to think what is the cause of cardiac arrest, but they've expanded it a bit for the pregnant woman to BOCHOPS. And your BOCHOP stands for bleeding or DIC, E stands for emboli, which can be coronary, pulmonary, or amniotic fluid. A stands for any anesthetic complications. U stands for uterine atony. C is for cardiac diseases. H is hypertensive diseases like preeclampsia. O is to think about your H's and T's, so other. P stands for placental abruption or previa, and S stands for sepsis. So they've expanded your H's and T's, so it's a little bit more complicated. So obviously your team leader will hopefully think about these things and bring them up whilst you're resussing. a little reminder of a resuscitative hysterotomy. So you only do it if your patient is over 24 weeks. And the aim is not to save the baby. The aim is to focus on maternal resus. And by doing the hysterotomy, we're hoping to improve that aortic valve compression. And we're trying to increase our chance of maternal ROSC. Obviously, if you're going that route, you need to involve OBS very early. Or if it's just you, you're going to go for it with a simple blade, making an incision all the way from the Ziffy sternum, past the umbilicus, down to the symphysis pubis, and then going through your layers very quickly, delivering the fetus, and very, very quickly, very quick staples or sutures just to close the uterus, but there's going to be no bleeding because mom is in cardiac arrest. And only if you've got a baby that's in a viable category would you consider calling peds at that stage. And it's not a completely sterile aseptic procedure. The aim is to get maternal ROSC. Going into the next slide. So Francois also initially brought up in his answer about doing an EFAST in pregnancy. And we normally do our EFAST for our standard trauma patients, and it's important to consider the little nuances that may be different for your pregnant patient. And there's been 3 retrospective case studies that have looked at the sensitivity and specificity of abdominal ultrasounds in actually detecting intra-abdo injuries in our pregnant trauma patients. And it's actually found to be potentially less sensitive across these case reports and retrospective case studies. And that's because with increasing gestational age, they theorize that there's compression of the paracolic gutters, and that may alter the abdominal flow in late pregnancy. But it doesn't mean that you shouldn't do your EFAST. I would still by all means do it so that you can pick up abnormalities like subchorionic hematomas, which you may see. And obviously, if you're seeing a huge clot or a large amount of free fluid in the abdomen, your sensitivity will increase. On to the next slide. We talk about the fetal fast. So the fetal fast is an extension of our EFAST that's specific for your trauma pregnant patients. And it's very simple. You're asking 3 questions. Is there fetal heart rate? Is the fetus viable? So over 28 weeks. And you could estimate this gestation by looking at the femur length. If you're a very astute sonographer in the emergency setting, you could look for a few extras like cranial fractures or Spalding signs. You can see features of intracranial hemorrhage in baby. You can have a quick look at the amniotic fluid volume and note whether it's less or decreased, the actual placental location, and if you're very, very astute, you can see a subchorionic abruption, which is on the slide, which can suggest a placental abruption. But again, those are things that you may or may not see. The important things is to do your fetal fast so that it can help you to make decisions later on for baby if needed, whilst bearing in mind that mom is always the priority. So I thought I'd just talk a little bit about the Clay-Hauer-Betke test, or the KB test, and comes up a lot in exams. And it's basically a blood test that we use during pregnancy to screen maternal blood for the actual presence of fetal red blood cells. And it's mainly used to assess the severity of a fetal maternal hemorrhage. So obviously in the setting of this talk, we're assuming that there's a placental abruption or a uterine rupture or any disruption in the placental barrier. And basically fetal blood is entering the pregnant individual's blood circulation. And it allows us to quantify the fetal maternal hemorrhage, and you need literally less than 5 moles for the test to be sensitive. And basically we use it to see, do we need higher doses of rhesus immunoglobulin? And in ED, we're giving the highest dose anyway to rhesus negative patients. And if they have significant abdominal trauma, if your patient's in her first trimester, she should get 50 mics IMI. If she's in a second trimester or above, she should get 300 mics IMI. We talked a lot about drugs during this presentation, including simple analgesias, complicated analgesias, and drugs of induction. And these are a few more of the ED-related drugs that we'd have to think about. So the famous cyclocapron or tranexamic acid and the CRUSH-2 trial. CRASH 1 and CRASH 2. Tranexamic acid has been studied in your obstetric patients in the setting of PPH, but the CRASH 2 trial excluded pregnant patients for obvious reasons, and they've listed tranexamic acid as category B. Because they obviously couldn't do an RCT on this, but they suggest that it's likely beneficial in polytrauma, considering that it's beneficial in PPH. ATT and rabies immunoglobulin are also safe in pregnancy, so please don't withhold those meds from a patient who meets indications for them. There's no cure for tetanus and there is no cure for rabies. So if your patient has an indication, please do administer it. Tocolysis is also always an option in a patient who's viable and has in the setting of trauma and has active labor. And obviously, I would do it in consultation with your friendly obstetrician. But remember, we always have salbutamol in the ED, and that's something that you can consider. Please don't forget to give steroids to your patients that are actually viable. And then we're looking at the studies that have been done on prophylaxis for seizures in TBIs in trauma patients. Obviously, no pregnant patients have been included in those trials, but most of our TBI polytrauma patients, the evidence shows that there's no need to give an anticonvulsant in the first 24 hours. It has no benefits in preventing seizures. So if you do want to eventually load your patient, if she's got a severe or moderate TBI, Keppra would be your anticonvulsant of choice in these patients. This is just something to consider in your pregnant polytrauma patient, that besides all the normal injuries that Doc listed when she gave her answer, which includes your pneumothoraces, your hemothoraces, this patient had a fracture, don't forget about obstetric complications of trauma in pregnancy. And this includes things like your abruptios. The patient can have an APH, her uterus can absolutely rupture, and obviously those are going to be your very sick, unstable patients. They can obviously go into preterm labor, preterm rupture of membranes. Fetal injuries can occur, but obviously it's not a priority for you because maternal resus equals fetal resus. Obviously, you're only going to look for fetal injuries if baby is viable and has a pulse and mom is stable. And don't forget about RBC isoimmunization. And then finally, just a little reminder on the cardiac arrest algorithm in pregnancy. And as I'm sure you can see, it's essentially exactly the same as our normal non-pregnant cardiac arrest algorithm with a few nuances. So it's still your same high quality CPR, defib as needed, adrenaline dose, same as needed. And considering your etiologies or arrest, we've expanded our H's and T's to include both chops. And very importantly to remember, if you are doing CPR on a pregnant patient who is in an appropriate gestational age, to please displace your uterus appropriately, either manually or with a pillow or 2 bags of IV fluids or a folded blanket under the hip. During your circulation, as you're going through your entire algorithm, which does not change, to do your continuous lateral uterine displacement, think about aortic-Cavall syndrome. The evidence does suggest that you should try and place your IVs above the diaphragm. And to try and consider your not perimortem anymore, resuscitative hysterotomy at least 4 minutes into your cardiac arrest algorithm. And although I haven't personally done one, I'm sure people at Rahima have seen it being done more frequently, or if at all. But just thinking about how I would approach a resuscitative hysterotomy in the algorithm would be, number one, to alert my team that there's a possibility that we will be going down this route, and carefully considering that, quickly putting a probe on the abdomen to see, is mom over 24 weeks? Can we consider this? Is it going to increase her chances of maternal ROSC? Alerting your obstetric team early if they are available on your site. And always bearing in mind that there should be somebody counseling this patient's family because it is a very traumatic process for yourselves and the family, especially if the resus is not successful. And always consider maternal benefits throughout your algorithm, and not to really think about or not let fetal benefits or risks blind our management in the management of our pregnant polytrauma patients. And those are the main pearls that I have.